Thanks very much for the kind introduction. So as mentioned, I'm Luka Milosevic. I'm a neuroscientist and an engineer here at the Krembil Institute, also a professor of biomedical engineering at the University of Toronto, and I work in the field of neurotechnology, where we are harnessing the power of bioelectricity to develop new brain circuit therapies. And hopefully that doesn't sound too far-fetched. I'm sure you're all very familiar with a cardiac pacemaker. Well, I work on a therapy that can be considered as sort of the brain equivalent to a cardiac pacemaker, and this therapy is called deep brain stimulation, or DBS. It's essentially a fully embedded system that involves a pacemaker in the chest that's used to deliver very low-intensity electrical impulses to particular areas of the brain that are implicated in disease. And in the same way that a cardiac pacemaker is used to correct irregularities in the heartbeat, our DBS devices are intended to correct or override irregularities in the electrical activity of brain circuits implicated in disorders like Parkinson's. And we happen to be one of the pioneering institutes of this therapy. So I am in the operating room for every surgery that we do here at the Toronto Western Hospital just next door. So we do about 150 surgeries per year. We're the highest volume center in Canada and one of the highest volume centers in the world. And I'm involved in performing recordings of brain activity during surgery. So what you're about to see and hear is the activity of a single neuron in the brain of an individual with Parkinson's. Can't hear it, but you can see it. So the reason that we do these recordings is actually to help guide the placement of our electrodes. So I'm essentially trained as an interpreter, and I can pretty much help pinpoint exactly where we need to implant the electrode based on the language spoken by the neuron. So if you imagine yourself on a train traveling through Europe, if you had a sort of a well-trained ear, you'd probably be able to tell exactly what country you were in based on the language of passengers jumping on board the train. In the same way, in the operating room, we can tell exactly where we are in the brain based on the language spoken by the neurons. So we actually use this information then to make sure that we're implanting the electrode in the correct area of the brain, where we're going to sort of ensure that we get the best possible outcome for our patients. So when we find the right spot, we can essentially stop a person's tremor with just the press of a button, and this is what it looks like. Yeah, so it's an incredibly gratifying feeling to be involved just in this process. It's oftentimes a very emotional moment, especially for our courageous patients when they, experience this first moment of tremor freedom in possibly over a decade. So it's just incredible what we can do. We can have an immediate impact, but as Jaydeep said, we can stop a tremor, we can do a good job, but not necessarily a great job. So there's still lots of room for improvement. So yeah, as mentioned, sort of this is my clinical role in the operating room, but I'm also a neuroscientist and an engineer. So I'm very motivated to make this therapy much, much better. And I'm privileged to be able to leverage the intraoperative environment and this incredible window of access to the human brain for research purposes, essentially. So one of the specialties of my lab involves the delivery of electrical stimulation while we're recording activity of individual neurons in the brain. And we do this to sort of better understand how DBS works and how precisely we're changing the neural circuit function, and then how these changes subsequently manifest a therapeutic benefit, which we can assess in real time in the operating room. So as I mentioned, and as you saw, it's a very remarkable therapy, but there's lots of room for improvement. And one of the main limitations I want to just kind of make you aware of is that the therapy currently relies on stimulation 24 hours a day. So it's not necessarily the most efficient in terms of battery usage, but as you might have noticed in the video also, as soon as you turn the stimulation off, the symptoms come right back. The other thing is that it doesn't really do anything to the underlying neurodegenerative processes of the disease, and in fact, the disease continues to worsen over time. So you're probably all familiar with the concept of neuroplasticity, or you've heard the term neuroplasticity before. So it's the incredible ability of our brain to essentially modify the strength of its connections in order to adapt to our environment or day-to-day needs. And what we've discovered is that we can actually use deep brain stimulation to rewire connections in the brain and to produce long-lasting neuroplastic changes. So this is pretty much changing, it's a paradigm shift in terms of how we're applying deep brain stimulation. So we've identified very specific pathways in the brain that are involved in regulating movement, that are underactive in the context of Parkinson's disease. And we've recently demonstrated that we can actually use very specific patterns of activity to enhance the strength of these connections. And this strengthening actually lasts a very long time, even after stimulation is stopped. And the best part is that we're finding that the therapeutic benefits of the therapy can also last for a very long time, even after stimulation is stopped. So we're actually making exciting progress towards actually fixing the underlying neural circuit problem instead of just sort of masking it. I want to just leave you with a final glimpse of the incredible capabilities of DBS. So this is an individual with a rather pronounced Parkinsonian gait disorder. And you can see in the video on the left that just in the amount of time it takes for her to turn around, she's able to make it down the hall and back in the video on the right with stimulation on. So what we're working on is new methods of stimulation, essentially to rewire connections in her brain and to enable her to do this even in the absence of stimulation. And we think that if we can retrain these important brain circuits, we'll not only be able to offer her the symptomatic benefit, but actually slow down the course of the disease as a whole. Thank you.
Oh my goodness, another amazing presentation. Thanks, Luka. So yeah, I think it was really stunning, not just seeing the woman, but also that hand, you know, and what happens. The tremor stops when DBS is turned on. I imagine that...
Attention, please. Second, code blue, Cell Pavilion, third floor, MRI, room 515. Second, code blue, Cell Pavilion, third floor, MRI, room 515. Second, code blue, Cell Pavilion.
3 times.
Oh, 3 times. Okay. I find it disturbing that no doctors jumped up to go and help this person. I don't know, like, shouldn't somebody be going? Anyway, okay, so Luka, just going back, I'm really struck by the fact that you're doing, I don't know if you'd call it real-time research, but you're right there in the operating room, right? Which, and I don't think you've got all day in there. So how do you do that on-the-site research, and then you're building on that?
Yeah, certainly the major limitation of this type of work in the operating room is that we're very much limited in terms of time. Of course, we have to get the surgery underway and make sure that we finish in a timely manner. So, I mean, at the end of the day, we can gather extremely important insights in the operating room. There's no other context than during surgery that we can record from these areas in the brain at this, spatial and temporal resolution. So we can gather really valuable neurophysiological and mechanistic insights in the operating room. Of course, these patients then end up getting chronically implanted with these devices. So if we want to test new paradigms, we can follow up with them outside of the operating room. We can assess time course of effects over the course of hours or days or months or years. But then the other thing is that in addition to being in the operating room 150 times a year, I have a preclinical lab upstairs here in the Krembil Discovery Tower. So we can actually take these initial insights in a person and then reverse translate them, and we can pretty much optimize our methodology in experimental models of Parkinson's disease, and then we can essentially bring them back to the clinic. So yeah, I mean, probably not too ambitious to say this is maybe the only place in the world where we can take an insight in a person in one day, take it back to the lab the next day, and then bring it back to the clinical setting the very next day. So
right.
We're very efficient, and we're not looking to make a breakthrough in a decade or in 2 decades, but hopefully a meaningful impact, today.
Yeah, that's fantastic. All right, thanks so much.
Thank you.